Hope you all have seen all the lectures very interestingly. And this is what I'm going to deal with, the emergencies of oncology, CA lung patients who come in our casualties. Okay. Introduction. The disease course in lung cancer is generally characterized by high morbidity and complications. Lung cancer emergencies can be defined as an acute, potential, life-threatening condition in a cancer patient, either as a direct or an indirect effect of the underlying malignancy or secondary to its treatment, requiring rapid interventions to avoid death or severe morbidity. Emergencies can occur at any time during the course of a malignancy. Lung cancer emergencies are common in emergency medicine also. Oncological emergencies in lung cancers are, some of them I have enlisted. First is airway obstruction. Second is superior vena cava syndrome, acute pulmonary thromboembolism, pericardial tamponade, massive hemoptysis, pleural effusion, pneumothorax. We'll see one by one each. Airway obstructions. As it has been explained by the doctor that the cancer patients, CA lung patients will get airway obstructions. And airway obstructions cannot be treated with mechanical or systematic medicine. So malignant airway obstructions refers to a mechanical obstructive process that impedes the airflow within the central airways, trachea and central bronchi. It has a significant impact on quality of life and is a substantial source of related morbidity and mortality. As the airway obstruction is there, and if it is not treated within seconds, there will be brain damage. So the quality of life of the patient will not be a good thing. So it usually presents in the advanced stages of disease progression. Most individuals have limited life expectancies. Physiological and psychological distress in patients as well as the family members. Airway obstructions may present as imminent respiratory arrest or suffocation. Decreased cardiac output related to reduced air entry may be seen. Patients will report gradual slowing down of activities of daily living. Easily fatigued and lethargic. There will be shortness of breath, dyspnea on exertion or at rest. Here you can see there's airway blockage during obstructive sleep apnea. This is normal, where the patient is not getting apnea obstruction is there. And you can see the universal sign of choking. This is normally seen in the CA lung patients. The management of airway obstruction is traditional treatment modalities such as chemotherapy and external beam radiation do not provide immediate relief. As we can see, these patients will be coming with stridor. So what we need to do is give oxygenation and ventilation is essential. Debulking of the growth surgically or with laser surgery, like we take the patients for tracheostomy. Progression of the disease, life expectancies, and patient's general conditions are the key point in decision making. Next comes the superior vena cava syndrome. You all know the superior vena cava system, when the patient is coming with this, like you can see the mediastinal mass, the patient will be in distress. So this is superior vena cava obstruction, is the obstruction to the blood flow through the superior vena cava. So there is no blood flow supplied to the part of the brain and the heart. Develops quickly and gradually. The causes can be pathological, such as compression to the blood vessels or invasion by the tumor or thrombosis in the veins. Lung cancer or lung metastasis is the most common cause. Here in this figure you can see superior vena cava syndrome. There you can see edematous head and neck with nasopharyngeal edema. Then appearance of the collateralized chest wall veins. You can see the veins very much tight. There will be swelling of upper arms and the torso, and you can see the cyanotic appearance of the skin. The symptoms and the signs what the patient will be looking like. There will be dyspnea, there will be facial swelling, heaviness in the head. The patient will be complaining of heaviness in the head. There will be cough, arm swelling as the figure has showed. They will complain of chest pain. There will be dysphagia. They won't be able to swallow. Then there will be hoarseness of voice. What all investigation we can do? We can do the X-ray chest scan, the CT scan where the tumor will be localized, MRI to check for the metastasis, and contrast venogram to check for the embolism. Management. The goal is to relieve symptoms and attempt to eliminate the causative factor for the compression. Radiotherapy. As Sir has already taken, the radiosensitive cancers like non-small cell lung carcinomas are treated with radiotherapy. Chemotherapy provides both local and systematic therapeutic activity only, but it is not effective that much. Then there are patients who are having thrombosis. Those patients are treated with thrombolytic therapy, like injection streptokinase and urokinase have been used for them. Then anticoagulant therapies like injection heparin is given, or oral anticoagulants are also given, like warfarin is given. Transluminal angioplasty with balloon technique or self-expanding stents are done. This procedure is done in the IR department. They are expert in that. Surgery to relieve the obstruction is bypass grafts, only done when no therapeutic methods are exhausted. Then only bypass grafts are done for these patients. Supportive management is given by giving bed rest, by giving Fowler's position, oxygen supplementation, and steroids are included in supportive management for these patients. Cardiac tamponade. Cardiac tamponade is a life-threatening complications characterized by excessive accumulation of fluid in the pericardium, resulting in the compression of all cardiac chambers leading to the lung. As the heart is there in between the two lungs, when the fluid is increased, the heart is pushed back. So this leads to decreased cardiac output, decreased stroke volume, compromised coronary artery filling, myocardial infarctions. This fluid may be blood, pus, or air. Accumulation takes place fast and causes compression of cardiac chambers, usually seen in the end stage of lung cancer patients. But 80% of the patients, when they are diagnosed, are in metastatic stage. Here you can see the healthy heart and the cardiac tamponade place. You can see the arrow where the fluid is fluid. Now this is the pathophysiology of cardiac tamponade. The fluid within the pericardium puts pressure on the heart. This pressure prevents the heart from expanding completely and filling to the capacity with the blood, which leads to less blood leaves to the heart. That's why there's too little oxygen reaches to the tissue, which leads to faster heartbeats, rapid fall in blood pressure, faster breathing, feeling of panic, swollen neck veins, which leads to loss of consciousness and even sudden death. What are the signs and symptoms of cardiac tamponade? You have to remember 3 Ds. That is distant heart sounds, distended jugular veins. Here you can see in the figure. Then there will be decreased arterial pressure, tachycardia, narrow pulse pressure, dyspnea. You can see central cyanosis, that's in the mouth you can see, and restless and anxiety with the patients. Management. The goals are to save life, improve cardiac functions, and relieve symptoms. Pericardiocentesis, that's invasive removal of excess fluid from the pericardium. This is done in the IR procedure. Removal of 5 to 10 ml of fluid improves the cardiac function drastically. The patient feels quite better. IV fluids to improve the cardiac output, supplemental oxygen, providing propped up position to the patients, and we need to give antibiotics for the patient as to prevent infection. We don't know what may be the content of the fluid what is present over there. Sometimes we send the sample after collecting for cultures also. Complications of untreated cardiac tamponade. If it is not treated, what could be the consequences? The patient can have cardiac arrest, myocardial infarction, abnormal heart sounds, injury to the cardiac muscles too, puncture or rupture of coronary arteries during pericardiocentesis. There can be hemothorax and pneumothorax too. Nursing responsibility. As we all are nurses, when the patients come post-procedure to our department, we should do regular monitoring of the vital parameters, assess their neurological status, check for the consciousness, how much they are able to answer to your questions. Then if you find anything which is abnormal, should be prompt reporting to the treating physician so that prompt actions can be taken. Provide assurance and support to the patient as well as to the family members because they are in distress. Next is massive hemoptysis. As we all know, our patients come in metastatic stage, so they come in a late stage. Massive hemoptysis is spitting of blood derived from the lungs or bronchial tube as a result of pulmonary or bronchial hemorrhage, classified as mild, moderate, severe, massive, and life-threatening. These massive hemoptysis is really life-threatening. Massive, when we say massive is when more than 600 ml blood loss over a period of 24 hours at a rate of more than 100 ml per hour, regardless of whether abnormal gases exchange or hemodynamically stability exists. When the patients come saying that we have got spitting or we have been spitting blood, when they come to the casualty, we have to ask them how much it was. Can you approximately tell so that we can treat them accordingly? Because they will just say we have just spit it out. That's not the reason because that's not counted. It can be spit also, it can be cough also, but we should say approximate how much it was in 24 hours. So accordingly, we should take it in on emergency basis. The source of massive hemoptysis is from bronchial artery and the pulmonary arteries. Here in this picture, you can say, patient may say, I have just spit it out, but some patients will be just, when you give a kidney tray, it will be full of kidney tray. So what are the causes of hemoptysis? Malignancy, as the patient is diagnosed with cancer, he has malignancy. Then it can be metastasis, as it has distant metastasis. Bronchiectasis. Now, bronchiectasis is what? The lumen, here in the picture you can say this widening of the artery and the cuff, what is there, is just left out over there. Even that can give infection. Emphysema. Emphysema is, you can see the normal alveoli and the alveoli with the emphysema. There is loosening of the alveoli. That's why there is no exchange of gases taking place. There will be gas going and the carbon dioxide is coming out. Then alveolar hemorrhage. Then there's pulmonary artery aneurysm. These are the causes for massive hemoptysis. What investigations do we do? X-ray chest. Bronchoscopy will tell us where exactly the bleeding is in. The CT scan to check out whether it's the primary or the secondary. Then arteriography has to be done. Blood investigation. Any patients who come with bleeding, we have to do a complete blood count. That's CBC. We have to do the coagulation time, grouping, cross-matching. We don't know what is the HB level of the patient. So we need to transfuse. And we have to give the patient a bed which should be near just in front of our eye so that we can monitor them very nearby. Management, prompt intervention is essential. Oral suctioning and clear the obstruction. Provide mechanical ventilation and maintain oxygenation. That's very important for the patients because if the patient is bleeding as it is, their HB will be low and they'll have breathless as it is and lethargy. Then fluid replacement, as the patient won't be able to take anything orally, so we have to give them to maintain the circulatory system. Identify the bleeding site and control it. By doing the bronchoscopy and all that, we could know where exactly the bleeding is taking place. Replacement of blood loss. That's very important because as soon as you send the grouping and the cross-matching is done, we should reserve the blood and accordingly we should give transfusion. When the HB is low, we should transfuse it very slowly over 4 to 6 hours. And then next you can give in between 4 hours. Malignant pleural effusion. Malignant pleural effusion is diagnosed based on the presence of malignant cells in the pleural fluid cytology or tissue biopsy reports. As you all must have seen patients with ICD, we send the patient sample for pleural fluid for cytology. So that's what we come to know. So in that, it's not sent for 1 day, it has to be sent for 3 days, regularly, every day. Patient may go home, we send the patients back home after the post-ICD insertion, but next day we call them so that we have to send the report. Otherwise, we gave them bottles so that they could collect. They need not have to call the patients back to casualty. Their attendants can get the bottles of the cytology. We teach them how to get it, how to collect it. Approximately 50% of lung cancer patients develop pleural effusion during the disease course. Here in this picture, you can see left hemithorax, normal lung is there, and right side you can see the effusion is there, where the lung is pushed back. Puncture point is also located. So when we assist for the patient for doing ICD insertion, we should be aware where exactly we should prick the patient, puncture the point. In the second picture, you can see there's ICD inserted. The fluid is pushing the lung back, and then the bag is attached. The bag should be under the chest level, not above the chest level. Now, what are the signs and symptoms of pleural effusion? There's dyspnea, which is subacute and progressive in nature. There will be a nagging cough for the patient, and chest discomfort. There will be weight loss. Suddenly, all these lung cancer patients, within a month or so, they'll be losing a lot of weight. 15 to 20 kg weight loss will be there within a month. So they will look typical cancer cachexia patients. Then they'll have anorexia. They won't be feeling like to eat, and they'll feel fatigue. Even by sitting or changing their position on the bed also, they'll feel fatigue. Investigation. A detailed history is very important. If the patient has taken tuberculosis treatment or was diagnosed with tuberculosis, has not taken, then also there are chances for the patient to get this. Then physical examination is very important. X-ray chest is a diagnostic for effusion. Thoracic or ultrasound helps us to detect the exact amount and location of the effusion. So this is done in the casualty so that we can do the ICD very well. Fluid is sent for cytology, fluid cytology to detect presence of malignant cells. Management of pleural effusion. Management is goal-oriented and individualized. First is to relieve of dyspnea, permanent control of fluid accumulation, prevent the need of re-intervention. That is when we do the effusion ICD insertion. So we don't want to do it re-interventions for the patient because we keep it for not 1 day. It has to be there for 2-3 days at least. Reduce hospitalization, decrease hospital stay. After doing the RCT incision, we don't have to the patient does not need to be there, admitted in the hospital. We just keep it overnight in the casualty, and next day morning we teach them how to collect the fluid and we send them back home. Placement of intercostal drainage for drainage of fluid. Fluorodosis to control the fluid accumulation. Can you tell me what do we use for fluorodosis in our hospital? Yeah. That large amount of fluid is drained in a controlled manner to reduce the risk of free expansion of pulmonary edema. Nursing assessment. Obtain history of previous pulmonary condition of the patient. Assess patient for dyspnea and tachypnea. Auscultate and precast lungs for abnormalities. Maintaining normal breathing pattern. Assist for thoracosynthesis. Maintain chest drainage system. Provide care after fluorosis. Administer prescribed analgesic as the patients will be there in very bad pain. So we should not just say, no, dard nahi hai, abhi diya tha, abhi nahi denge. We should assess that we should administer prescribed analgesics to the patient. Observe patient's breathing pattern, oxygen saturation. That's very important because this patient can deteriorate at any time. Within a span of second also they can deteriorate. Administer oxygen if indicated. Now we'll go to pneumothorax. Accumulation of air in the pleural cavity causing lungs to collapse, commonly seen in mechanically ventilated patients. Can occur as a complication of post-lung biopsy or invasive procedures. Can also be a result of closed trauma to the chest cavity. Even when we do fluorosis, that time also it can happen. So accumulation of air builds up pressure in the pleural cavity resulting in lung compression and lung collapse. The sign and symptoms, there will be tachypnea, tachycardia, dyspnea and shortness of breath. Suddenly they'll complain. There will be pleuritic chest pain. Here in the picture you can see. Then there will be peripheral cyanosis you can see in this kind of patients. Hypotension will be there and there can be shock also. We don't know any time the patient can go into shock. Investigation and diagnosis for this patient is physical examination to look for tracheal deviation, distended neck veins and unilateral chest movements. These are the typical physical examination what we do. That time we can notice this. Chest auscultation detects unilateral air entry. Chest X-ray is diagnostic for effusion. Chest ultrasound, chest CT. Management. Goal is to evacuate the air promptly from the pleural cavity and facilitate lung expansion. If the air is not removed, there will be lung collapse. So it has to be done immediately. Supplemental oxygen to treat hypoxia. Simple aspiration to remove the air. Emergency decompression for tension pneumothorax has to be done. Nursing responsibility. Monitor vital signs regularly and record. Observe the movement of the fluid column. That's very important. Regular emptying of thoracic drain and maintaining the underwater seal. You should not empty just as if we are emptying the urinary bag or any other drainage bag. It should be properly done because we need to put a water seal under that. Clamping of the drain during shifting of patient is very important. We should remind the relative and our labor staff to keep it clamped when the patient, we should clamp it. Otherwise also we should recheck it. Plus keeping the level of the bag under the chest level. Report to the clinician in case of any changes noted in the color, consistency and odor of the fluid. That is very important. Observe the insertion site for any oozing or soakage of dressing. If it is there, we should inform. Post ICT insertion, we should do X-ray chest is very important so that we could see whether it is proper or not. Secure the insertion site with proper dressing. Post removal of drainage tube also. And it is very, very important to check the dressing site. Conclusion. Due to often late-stage diagnosis and widespread metastatic disease and aggressive in nature, oncological emergencies and urgencies are relatively frequent in the lung cancer patients. There are many paraneoplastic syndromes associated with lung cancer, and they can be extremely challenging to diagnose and to manage. The role of the oncology nurse is crucial in managing and the continuing care for lung cancer patients and their families. Thank you for your attention. Any questions?
No questions? Thank you, Vaishali. It was a nice lecture.
Thank you.
Thank you. Now,